Good morning, and welcome to the second day of GIEQs 2. I'm here welcoming you on behalf of our esteemed local organising committee, who you can see here, and I'm here with Dr. Ronan Valori, Professor Peter Hendricks, Dr. Lopke de Zomer, and Dr. Christoph Schunyans, representing the organising committee this morning. We're really grateful to our sponsors, without whom we could never do this, and particularly we're grateful to our platinum and gold sponsors, without whom this symposium would not be possible. Why are we doing this? So this is the second edition. We've got more than 500 participants. Thank you so much, every one of you, for registering and believing in us, a little startup, Geeks in Endoscopy Education. 37 countries involved from a broad range. And this is what we were doing yesterday. You can see that we were all having quite a lot of fun, a lot of discussion about what you might do in the duodenum if you made this sort of a...
Right. My name is Ronan Valori. I'm going to be moderating this next session on upper GI imaging. I've got a great team to support me today. We have Professor Ralph Bishops in the live endoscopy room doing some endoscopy. So, Christoph, please. Christoph is going to talk about real-life imaging in the stomach, and then we're reversing the order, and David will come back and talk about real-life imaging in the esophagus. Christoph.
Yeah, thank you. So we assembled a few videos again of lesions in the stomach, and we're gonna look at them together. Just gonna let this play. This is a patient. This was referred. He has an anastomosis in the stomach, and it was referred for suspicion of a cancer at the anastomosis, for an inspection here and for resection if possible. So we're just gonna let the video play, and I would like to hear.
So what was the anastomosis for? What?
I think it is a gastroduodenal anastomosis.
Yes.
I don't know what the reason for the surgery was.
Yeah. So the first question is whether we regard the risk of cancer to be higher in this situation. What would you say, Lopke?
I'm not sure. So, can you explain? Have you got more information about this, or we have very little?
This is the only information you're getting.
Okay.
So it's possible that he has a cancer in the antrum, but I'm not really sure. We had a distal gastrectomy. This is the anastomosis, and there's something on the anastomosis. What do you guys think of it? Is this something suspicious? Here are the NBI images.
Yes. Suzanne, do you want to make a comment?
We see many times in the gastrectomy anastomosis or in scars hyperplastic tissue, because it's very common. But of course, the surrounding mucosa in this case can sometimes also have other pathology that needs to be careful examined with biopsies, because there are risk of synchronous lesions. Yeah.
We put some metal in blue on it, and I have to say, if we're looking at the pattern of this, I think it's this inflammatory tissue, and we don't think that this is a cancer. So
okay.
Biopsies would, yeah.
Yeah. So Suzanne, as a digestive oncologist, if this was a gastrectomy for cancer, then you would be probably much more on your guard than it was gastrectomy for any other reason.
Of course, I would also be concerned, even if it is only hyperproliferative polyp, hyperplastic polyp, because you don't know what is underneath it, and there is a risk of a neoplastic transformation also. In this case, only biopsy. It is not. We don't have the real picture of it.
This is what was done. The biopsies were taken and were all reassuring. So this patient was not referred to a surgeon for a new operation.
So what's the plan with this patient then? Do you just say, well, the biopsies are fine and that's it, or do you offer surveillance, or what?
It may depend maybe on which biopsies, what the biopsies show of the more proximal stomach, if there is atrophic gastritis or intestinal metaplasia.
Yeah.
They might let it depend on that, I suppose.
Yeah, I agree.
Do you think you can tell atrophic gastritis without biopsies, just on imaging?
I think, you can, definitely.
I think we are getting better, but we are not there yet.
Yes.
Definitely not there.
Because that stomach didn't look particularly atrophic to me, but I
would...
Of an atrophic stomach.
Okay.
Looks pretty atrophic to me.
Sorry, what does?
Stomach.
Yes. yes.
I would
Right.
also give the patient the possibility to talk about maybe resection. Maybe he doesn't want. Maybe there is a risk of family history.
Yeah.
I would not be completely chill with that image.
Okay.
Yeah.
So,
And this is the next video that looks a bit different, I think.
Yes.
than,
I was talking about this one. My fault. This looks atrophic.
why does it look atrophic?
on the right,
Background
on the
because,
right, it looked more
and
right.
it's intestinal metaplasia on the pylorus.
You guys think this clearly looks
It looks-
malignant?
Yeah.
Raf was saying that he wouldn't offer surveillance in a short segment Barrett's. So we've now just looked at 2 cases with suspicious areas in short segment Barrett's. So any
Indeed.
comment?
That's a really great question, which always troubles me when I see these patients.
Yeah.
And I bet you're better to answer that than me, because you're much more of a systems person. You've got way more experience than me to answer that. I mean, doesn't it just come down to cost effectiveness and the fact that they're not common? This is not a common situation.
So, absolutely, that was the point that Raf made yesterday, is the number needed to scope or survey is very high with short segment Barrett's. So because of the relatively low incidence of cancer, it doesn't mean there's never cancer, it doesn't mean there's never high-grade dysplasia. It's just you have to scope an inordinate number of people to find one case. So it's not cost-effective compared to a long segment Barrett's. Is that correct, Suzanne, what he said, or not? Am I saying something he didn't say?
I think so. But of course, that when we see these patients with short segment, I would definitely biopsy them, because it can be the only opportunity that they have.
It's interestingly not in the typical place, right? But you're right, absolutely, it is just above. But you do see that, so this is maybe a little bit more of the normal pattern up here, and then they're totally going in different directions. They're all over the place in terms of their width, and the direction that they're pointing. So indeed,
And
this is... Huh?
And you wouldn't be able to see them if it was dysplasia in a Barrett segment.
Right,
So
yeah,
these
absolutely.
capillary, this pattern would not be there.
Yeah,
No.
so this pattern is specific, is what you're saying, Amir, for squamous.
Yep.
And what did the biopsy show? What did
But this is so actually we resected this endoscopically, and the pathology was a T1A squamous cell carcinoma.
Gosh, okay.
So Roland just said, gosh. Why did you say that?
Well, because I think 90-odd% of people would just never see that. So,
That's true.
99% would not. If the regular, we're looking at endoscopy here, which is largely being performed on propofol. What I'm thinking, how do you do this without propofol? How do you do this without all the imaging? How do you do this without the understanding? This is a massive task in the tens and millions of thousands of endoscopies we do to pick up that sort of lesion. I mean, looking at it now, there's a sort of different blink effect. There's obviously something going on there. But even so, we know that there's a big issue with and I think we'll finish on this, David, if you don't mind.
Agreed.
So one of my colleagues is doing a lot of work in England on post-upper GI cancer, very much like the post-colonoscopy colorectal cancer. And there's, as you might imagine, exactly the same problem with cancers appearing within a few months, a year or two of an upper GI endoscopy for a whole variety of reasons, as you might imagine. And not seeing this sort of thing obviously would be pretty high on the cards, really. So,
And especially because if you miss these lesions, the aggressiveness of these cancers are more than in the colon. You don't have that much time for it to be overt cancer.
I was slightly distracted. Absolutely. So you're saying the dwell time is much shorter. So you've got to get it right. You don't really have a second chance.
You don't want to miss the opportunity.
I think we'll finish on that note, that extremely important note. I think this has been a fantastic session for me, so it must have been great for everyone else, I would guess. I thank you, Amir, in Haifa. I'm really looking forward to meeting you face to face one day. And
If we can ever get him here.
And I thank you very much for the great moderators here. Thank you all and the speakers.